Good morning. I'm Jamie Rylands. I'm one of the senior clinical lecturers at the Liverpool School of Tropical Medicine. I'm going to be co-chairing this. I'll ask Steve Graham to introduce himself.
Yes, good morning. I'm Steve Graham. I'm with the Centre for International Child Health, University of Melbourne, and also the Child TB Lung Health Consultant with the Union. Thank you.
Great, so I'm hoping there'll be plenty of discussion and we'll leave plenty of time. A couple of speakers can't be here today, so I'm going to give you an overview of where we are in terms of pneumonia treatment. I'm going to flip between adults and children, not because they are at all similar, I'm told by my wife, who's a paediatrician, but because I think there's things that we can learn in either direction, admittedly mostly from paediatrics to adult medicine, and I speak as an adult physician. And then I will introduce all our three chairs and describe how we're going to take on the conversation. So there's clearly differences in pneumonia management where you can't put your hand up and say to the intensive care doctor, can you please get me out of the difficult position I find myself in? And in low-income countries there are also problems with treatment and monitoring. I'll just give you an overview of the landscape here. I should say that I don't have any conflicts of interest. And in perinatal mortality circles, trying to find barriers to reducing mortality has led the WHO and other people to describe these three circles of delays to treatment. This has been taken on by the sepsis community, and I think pneumonia, at least pneumonia that kills where you see it kill in hospital, is often as a function of the sepsis as much as the bacterial action. But there's components of the healthcare system we need to get right. Triage and diagnosis, resuscitation, monitoring and reassessment. And core to all these things is the training, the equipment, and the staffing. And there are a lot of problems. There are a lot of problems in getting patients to hospital. There's a lot of problems with patients getting through the hospital gates and accessing care. There's difficulties with finding who the ill patients are in triage, and we'll talk a lot more about that today. There's the laboratory and source control and imaging. And then when you get a diagnosis and you get a triage decision, and admitting people to the right place and having them monitored right is all very difficult and multi-systems. With a nod to that, I'm going to talk you through just some parts of the resuscitation and treatment, and then we're going to go backwards because most of the speakers are going to talk about how we refine who needs higher level care, what kind of care might be possible, and how we define biomarkers of that care. But I should give you some sort of endpoints about where we're going in terms of what that care looks like. From a patient point of view, you might consider this a bit more linear. They've got to recognise signs of illness, and a lot of this comes down to community recognition of symptoms and early access to treatment at a primary healthcare setting. But then we're talking about getting to hospital-level care, triages, getting a diagnosis right, and getting appropriate therapy. So as I said, I'm going to talk about these three things as an overview. Antibiotics. We discussed at this similar session last year, and there are clearly difficulties. There are difficulties compared to high-income countries, often because of a high rate of TB, and in sepsis patients, 30-40% of mycobacteremias in HIV-positive populations means that the initial choice of antimicrobials might need to be altered. There's currently an idea, at least where I've worked in Eastern Africa, that you step up treatment. So you start with a relatively broad spectrum cephalosporin to cover antibacterials. And when you're not winning, then you consider all the other diagnoses. And I think there's opportunities for that window of lost opportunity for anti-TB treatment and others to be shortened. And so antimicrobials we're not going to talk very much more about, but there's clearly complications, and there's fungal treatments that might be useful, but diagnosis of those is very difficult. So onto fluids. Fluids is a significantly difficult point, I think, both in paediatrics and adults. And amongst the three presenters here, I don't think there's any consensus that anyone would hold their hands up and know, I know what to do under all these circumstances. In the adult setting, the tendency since the early 2000s has been to give more and more fluids. This is where you have people in the emergency department who appear septic, maybe a respiratory infection, maybe something else, and early goal-directed therapy where you use considerable invasive monitoring of physiological signs to monitor treatment, but also to direct treatment in terms of the fluid volumes that you're giving, blood volumes and oxygenation. And this seminal paper, Rivers et al. Showed an odds ratio of 0.5 for an intervention cohort on an individually randomized basis compared to standard treatment. And a lot of that might be an increased use of fluids, but certainly a lot of extra monitoring in the emergency department, and well beyond what you can do in low and middle income countries. Interestingly, though, as time's gone on, this is a systematic review of 5 papers, 3 of which have been in the last couple of years. That difference between the intervention and the control cohorts, the intervention where you're giving more monitoring and usually more fluids, between 2 and 6 litres in the first 6 hours, those effects seems to have disappeared, and that might be a difference as we get a change in physician behaviour to giving more fluids and being comfortable giving more fluids. And certainly, as things stand, the composite endpoint for early goal-directed therapy is not very favourable, or at least there's very little advantage. That's in adults. And in paediatrics, FEAST study, which I think you'll have seen presented previously, and I'm just taking a single mortality graph from. This was a randomized controlled trial of children with a median age of just over 20 months, presenting with clinical markers of low perfusion, of suspected infection, and randomizing 3 ways in that population, either to maintenance fluids, to a saline bolus system, or to an albumin bolus. And you can see that these mortality curves diverge, but they diverge in a way that wasn't really expected, I think, by most people, in that people that received maintenance therapy rather than bolus fluids did better than others. And this might be due to any number of things. It might be due to reperfusion injury, to hypochloremic acidosis, to a lack of sympathetic drive where you give fluids. But there's certainly issues where you don't have intensive care in terms of knowing how much fluid you can give. It wasn't pulmonary edema. There seemed to be cardiovascular collapse of these children that caused the mortality. So in paediatrics, I think there's questions still about exactly how you monitor and how much you give. In adults, going back to adults, we have 2 studies really in sub-Saharan Africa. One a before and after study, and of course the tendency is that we find a great effect in a before and after study and then do later studies and don't see that effect or see it diluted. And that's what we see here. So this is Shevin Jacobs from Uganda, an intervention in a 2-year period between a before and after. Here I've called cohort 1 before and cohort 2 after, where the intervention was more support clinically, a clinical officer in place, a emphasis on giving more fluids and early antibiotics. And you can see beforehand there's relatively small amounts of fluid being given in the 6 hours. Antibiotics are less driven in the first hour than perhaps they could be. Interestingly, at this point, even for those that required antiretroviral therapy for HIV, only 30% were getting them, and there was a high mortality. And in the second cohort, 2 years later, there was a number of things which changed about the hospital system, but things that definitely did change as they were giving more fluids, they were giving antibiotics earlier. There was more availability of antiretrovirals, and you wonder how much that contributed to this decrease in mortality from 46% to 33% with this relatively large cohort. Was this the fluids that made the difference? Well, in terms of supportive therapy, this wasn't powered to detect. This is a sub-analysis of unpowered to detect this, but do show some divergence where there's 0 to 1,000 mils of fluid given in the first 6 hours. And then doesn't seem to be much of a pattern, but there certainly seems to be between 1 and 2.5 litres in this group. The subgroups seem to do better. Difficult to know how you take that in a before and after study. So we have one randomized controlled trial in adults in sub-Saharan Africa of fluids, and unfortunately this was stopped early. Their workup here in the Andrews paper showed there was going to be about 50% mortality or expected. And it was stopped after about just over 100 people were randomized to receive either 2 litres of fluids first up and then another 2 litres straight after, compared to a more conservative regime. And they noticed that there was high respiratory rates and low oxygen saturations in the people that were dying. They picked out some people that had a relatively high systolic blood pressure, but the safety committee decided they were going to discontinue this trial. So we don't have really a well powered endpoint. They noticed quite typically there was high rates of mycobacteremia, and they'd started off in terms of implementing their intervention relatively well. 1.6 litres was the average, and it went up to 2.8 litres afterwards. And so the mortality in this curtailed RCT hasn't told us very much to move the literature forward, unfortunately. So that's fluids, and I dare to say I don't know what I'm doing when I see patients in these circumstances. Other people may be more confident than me. In oxygen therapy, the presumption again is that oxygen is good. You can't do any harm with oxygen, and that rolling out oxygen in a healthcare setting is a good thing in secondary care. This is a study, rather unusual study, I think, from Canada, looking at community-acquired pneumonia, where they sent people home, and I think they managed to send people home who were hypoxemic, which is an interesting thing, and then realised that they did worse. So there is some relatively direct evidence that oxygen levels are inversely associated with survival from community-acquired pneumonia. And it's certainly, when you come back to hospital, you tend to get kept in if you're hypoxemic. And that would be, I think, our preference. But paediatrics, rather than just watching things as ever, have been a little bit ahead of the game here. And Trevor Duke, now published 8 years ago in Papua New Guinea, looked at a multi-hospital centre intervention study, again, before and after, but using oxygen concentrators to deliver oxygen to a very large number of people after this intervention, and looked to see a reduction in mortality of risk ratio of 0.65. So very significant in terms of the intervention. Whether it was the oxygen or not, I'll let other people decide, but there was certainly an opportunity to improve care for children with pneumonia where there wasn't intensive care units. There is still, I think, equipoise in how much oxygen, or whether you give oxygen to children who have borderline hypoxemia. And the COAST study, Kath Maitland, who led the FEAST study, is going to start recruiting to this next year. This is the COAST study, so they're going to, just to give you an idea of the landscape, they're going to take people who, children who have saturations between 80 and 92, and randomise those to receive no oxygen in the first place, to receive low flow or high flow oxygen. And in those with lower sats than 80%, they're going to randomise them to low or high flow oxygen to try and answer the questions, who do you give oxygen to and how much do you give? That's fine in adults. You can use one, in pediatrics, you can use one concentrator, and this is from Trevor Duke in the WHO's book, and you can deliver oxygen to a number of people. Relatively low flow rates, nasal, in what are more obligate nasal breathers, seems reasonable. In adults, I'm not sure. This is Steve Aston, who's going to be presenting his work, but he was a bit coy about presenting his own data, so I'm going to do it for him. And this is a pilot study of oxygen, asking the question, where you have oxygen concentrators as your main mode of delivery, is this sufficient nasally to rectify hypoxemic patients' oxygen levels? And the answer is, he took people who have SATs of less than 92% and gave them standard 5 litres of oxygen, which is what you might consider giving to adults, the first step, and then looked at 60 minutes to see what happened. And he took 59 patients that came in, and 51 patients out of 59 corrected on that amount, suggesting that oxygen concentrators, from the numbers point of view at least, are going to rectify the vast majority, 80-85% of hypoxemia. At 1 hour, Steve managed to get hold of a high-flow oxygen concentrator and dialed it up to 10 litres a minute and watched them for another hour. So the question then is, if we have oxygen concentrators that can deliver more in adults, is that appropriate? And 4 then corrected their hypoxemia and 4 did not, suggesting that there is a core of people who, for shunting and other reasons, don't correct, but that high-flow oxygen probably has a beneficial effect in terms of the oxygen saturations in a minority of people. And just to bring the current literature up to date, this is going to be presented by Elwyn Chick, another thing coming out of Blantyre, and will be presented tomorrow, looking at how long you need to give adults oxygen before they normalise. So parts of the puzzle in terms of when you're running a hospital, how many oxygen concentrators do you need for adults, and how long you're going to need them for, and we can use this for modelling, and then that might lead forward to a more RCT or step wedge trial of oxygen in adults. So, I should introduce our speakers. First, we're going to hear from Eric McCollum, who is at Johns Hopkins University, currently working in Bangladesh, living in Singapore, and he's done considerable work in Malawi looking at how you incorporate care, get access to HIV treatments, to oxygen therapies, and risk stratifying people with pneumonia. Then we'll hear from Steve Aston, who is a Wellcome Trust clinical fellow who's just completed his PhD in Malawi, looking at severity markers in people presenting to secondary care with pneumonia. And then Enitan Carroll, who is the Professor of Pediatrics with interest in infectious diseases at the University of Liverpool, who has done extensive work on biomarkers and asking whether they're the new thing and how we can use them to best stratify patients. So I'll hand over to Eric, and I'd like discussion whenever you want it, Eric. Either throughout or at the end.
Thank you, Jamie. Jamie, does anyone have any questions or clarifications on the presentation from Jamie as an introduction, which was excellent? No, okay.
Easy,
thank you very much.
Let's see if I can figure this out. Pressing the green button, right?
Something's happening.
All right. Okay, here we go. Great. Okay, so thanks for having me today. I'm Eric McCollum from Johns Hopkins, and I'll be talking about how can risk stratification benefit children with pneumonia. I have no competing interest to disclose. I'd like to acknowledge my colleagues, Kate O'Brien, Karina King, Tim Colburn, Keith Klugman, and Raza Azagnegdadar for their contributions to this talk. So I'll review how we currently stratify child pneumonia mortality risk in developing countries. I'll attempt to identify some key gaps and propose some potential strategies to address those key gaps. So child pneumonia, for those of you who don't know, it's the number one infectious cause of death in children younger than 5 years old globally, responsible for about 15% of all child mortality worldwide. The regions of sub-Saharan Africa and Southeast Asia contribute the greatest number of child pneumonia deaths globally. And we've experienced a significant amount of success overall in reducing child mortality over the past 15 years. And child pneumonia has reductions in mortality in child pneumonia has significantly contributed to that overall reduction in child mortality reduction. And that's been led in part driven by increased access to vaccines, antibiotics. And moving forward, those will continue to be the central pieces likely in reducing child pneumonia mortality. But what I'll talk about a bit today is how risk stratification moving forward is likely to have a more important role. And that's stemming from the fact that the current child pneumonia mortality landscape is comprised of a large proportion of children who are higher risk and have comorbidities. And so in order for us to continue to drive down child pneumonia mortality, we'll need to better identify these children, hopefully reduce the prevalence of risk factors or reduce the prevalence of comorbidities, but also have interventions that can identify them and ultimately improve their mortality outcomes. And so I'll talk about risk stratification today and potential strategies associated with that. And so I'll first walk you through a patient's kind of a journey through a generic developing country's health system. And hopefully this will contextualize risk stratification to everyone here. So the first step really in most health systems is that the caregivers will bring their child who's sick with pneumonia to a frontline health worker. So it's typically a community health worker or a village doctor, and this, depending upon the setting, can either work in the public or private sector. But these largely are health workers who are informal, don't necessarily have formal training, have relatively basic skills, and within their setting have limited diagnostics many of whom are medicalized in that they can provide antibiotics, but typically they will diagnose through timing respirations, but ultimately they're making a decision about the risk of that child and whether it's safe to send them home on antibiotics or not, or whether they need to refer the child further along in the health system. At the health center level, typically these are standalone facilities staffed by more formally trained healthcare providers. So that would typically be a non-physician clinician in most settings, or if the health center is fortunate enough, a nurse. But these settings will have more antibiotic options. They can typically provide an injectable antibiotic to a child who's sick, but they don't tend to have imaging modalities. They don't tend to have oxygen there, but nevertheless, these healthcare providers are again tasked with assessing risk and making the decision: do we send this child home with or without antibiotics, or is this child sick enough to refer along? And then at the health system level, or at the hospital level, hospitals generally do not have intensive care, but they do have the possibility of having more sophisticated care, at least diagnosis and treatment delivery. They're staffed often by non-physician clinicians under physician supervision, sometimes pediatricians, but primarily non-physician clinicians, nurses. And there are fluids. Fluids are available. Oxygen is often available, but not always. And antibiotics are available. Stockouts do happen. But again, here, there is emerging areas of where some hospitals are, for example, introducing non-invasive ventilation for children. But these are modalities that are rare, do require more resources. And so at this level, it's less about referring along and more about deciding who can best benefit from which intervention. And that's where risk can be helpful, I think, here. So the Pneumonia Etiology Research for Child Health Study is a large case control study and took place within 7 countries in Africa as well as Asia. And they were kind enough to share some preliminary data with us. And basically, this highlights the importance of children who have comorbidities are comprising a large proportion of patients with mortality. And so here, basically what this data is showing is that patients who are malnourished, who have comorbidities of malnutrition, diarrhea, have a very high odds of mortality, and these are hospitalized patients. And similarly, patients who have hypoxemia or other signs of severe respiratory distress, such as grunting, nasal flaring, also have a significantly a high odds of mortality. The Malawi Child Lung Health Program is a national standardized case management program for children hospitalized. And basically what this shows here is that from 2001 to 2002, children who received care in hospital within this program experienced a reduction in case fatality from 15% to about 4.5% over this period of time. But most notably, you can see here on this graph here is that patients who suffered from the comorbidity of severe acute malnutrition had no reduction in case fatality rate over the same time period. Again, supporting this notion that children with comorbidities are responsible for a substantial proportion of child pneumonia mortality. So we need to be able to stratify risk and have interventions to reduce their mortality in order to continue to see reductions in overall child mortality. And HIV continues to be a major driver of child pneumonia mortality, particularly in Africa. And this column that I've highlighted here demonstrates that the proportion of all pneumonia deaths attributed to HIV remains high, and it's particularly important in Africa. And so how currently is child pneumonia mortality risk stratified in developing countries? And so generally, most countries will use the WHO child pneumonia case management guidelines to structure how they treat children. And embedded within this algorithm is risk stratification. And so here what you can see is that in this red box, these are patients who are categorized as high risk. So these are patients who would be referred to the hospital and they have danger signs. This yellow box here are patients who do not have danger signs. And they instead have chest indrawing or fast breathing in isolation. These are patients who could receive oral antibiotics and they can go home. And the green box are patients who have no signs of pneumonia, just have cough and cold, and they can go home on supportive care. So the way that this works basically is that a child will come in to a healthcare provider. The healthcare provider will query about whether the child has cough or difficult breathing. The caregiver, if they say yes, then the healthcare provider is asked to count respirations, observe the breathing pattern and look for lower chest indrawing specifically, listen for stridor, audible wheezing, and basically more recently, what's been introduced, which is a great development, is that the WHO guidelines are recommending that in settings where pulse oximetry is available and oxygen saturation is then measured, and if that oxygen saturation is less than 90%, then that child would be categorized into this higher risk area. And other danger signs that would include going into this category are those children who have severe acute malnutrition, HIV, severe pulmonary pallor, convulsions, and other general danger signs. And so where are the WHO pneumonia risk stratification gaps currently? And so in my mind, there's primarily two. And so the first one I think is a rather obvious one, and we all struggle with this, and that's that the risk factors in the WHO guidelines are not optimally implemented. And so how do we optimize implementation? And so that we classify patients appropriately, we identify danger signs, and we get them into this red box so that they can be referred along the care pathway or get the appropriate treatment that they need. And the other gap, I would say, in my mind, is that the lower risk category is oversimplified in that patients who are categorized as having chest indrawing or fast breathing are all assumed to be low risk and are sent home on oral amoxicillin. And I would just kind of give the examples, and you can decide for yourself, but the guidelines essentially manage these two patients similarly. And the first patient would be one who's 3 months old, who has chest indrawing, an oxygen saturation of 92%, moderate malnutrition, and in that patient is managed, would be considered low risk, and would be managed the exact same way as a patient who's 3 years old, who has a normal oxygen saturation and is not malnourished. And I think that the likelihood is that the first example is a patient in which those moderate risk factors interact and would likely upgrade that child to being a higher risk patient. So I'll talk about that a little bit. And so we're back to our patient journey here, and basically the point I wanted to make on this slide again is that when you think about risk stratification, the capacity of the health system is going to be really important to consider. And so any interventions for risk stratification that are applicable to the health center and to the community health worker level need to be feasible and relatively straightforward to be implemented well at these levels. And they can have effect at these levels. Whereas at the hospital level, there is more nuance. There is a potential for more sophisticated risk identification. But in order for there to be, I think, true effect here, we probably need a more complicated way to assess risk. But that still remains feasible. It's a little bit maybe more challenging in its own right. And so I'll talk about pulse oximetry as an example of a tool to implement at the health center and community health worker level to stratify risk at those levels. And so we implemented pulse oximetry in Malawi over a 2.5-year period at the health center and community health worker level, embedded within a PCV impact study. And so basically we asked healthcare providers and trained them to measure an oxygen saturation in 2 districts in central Malawi for children who had clinical pneumonia, who are already classified. And you can see that over 14,000 patients were found to have clinical pneumonia during that time period at these health system levels, and more than 13,000 had a successful oxygen saturation measurement. And what that speaks to is that measuring an oxygen saturation at these levels of the health system is likely to be feasible. At least we found it to be feasible. And then in addition, among patients who were found to be clinically eligible for referral from these levels, a 2 times higher percentage of patients were referred if they had an oxygen saturation of less than 90% compared to patients who had an oxygen saturation of 90% or higher. And again, this supports the notion that a lower oxygen saturation measurement encouraged these providers to refer the patients along the care pathway. In this last box here are the patients, the 195 patients who were not clinically eligible, so they did not meet the WHO or the Malawi guidelines actually for referral, but they were found to have a lower oxygen saturation. And so the guidelines missed them. And we found that slightly more than a quarter of these patients were correctly referred. So this is a lower percentage, which suggests there's some more work to do here, and we're exploring reasons why with focus group discussions. But ultimately, this still is better, in my view, than 0. And then lastly, what we did with this data is that we took the current WHO guidelines, which does not refer chest and drawing, and we applied that to this data set under the assumption that pulse oximetry is not available, which is the norm. And we basically found the take-home point was that roughly 2/3 of patients at the health center and also the community health worker level who were found to be hypoxemic were not eligible per the current WHO guidelines, so they would be missed. And so the point here is that, again, this simple tool, relatively simple tool of pulse oximetry, has potentially significant utility in stratifying risk at these levels of the health system. And then also the other maybe point to just draw back in is that not all chest and drawing is the same. This other question here is where is in terms of optimizing pulse oximetry implementation at the lower health system level to stratify risk, comes back to where can we implement an oxygen saturation measurement within the individual patient's care pathway. And so right now it's recommended that we measure the oxygen saturation after the patient's been classified by the healthcare provider to have cough or difficulty breathing. And so that would then push the child, if it's low, into this higher risk category. But what this may do also is it may miss these patients who are incorrectly found to not have cough or difficult breathing. And we know that this happens. The respiratory exam in children is not necessarily always a straightforward examination. And not all patients will present with cough or difficult breathing and can still be found to have hypoxemia. It's a lower proportion of patients, but again, in terms of, if we were to ask people to measure oxygen saturations as more of a triage measure before they're even classified to have cough or difficult breathing, it may help to reduce that missed case issue and further drive down child mortality by correctly identifying these patients and pushing them into the correct care pathway. Now, to talk briefly about the hospital level, again, the hospital level risk stratification has more potential for sophistication, more potential for some advanced treatments, although we're not quite there yet. But this requires more nuance in dealing with risk. But risk scores are one way to deal with this nuance and complexity. And so I'll give the example of the South African Respiratory Index of Severity in Children score. So this is a risk score that was developed from a vaccine trial data set from South Africa, which is of children less than 24 months of age, all of whom were hospitalized with acute lower respiratory tract infection. And so basically what these investigators did is that they explored the data set for predictors of mortality and then basically picked out the predictors that they felt would be most pragmatic in a routine care setting. And then basically what they did is that they then would weight the different variable and its contribution to the model by using its beta coefficient and correlating that into a score. So they would round that beta coefficient up or down and generally would get a whole integer here. And so what they did basically is they stratified by HIV non-infected and HIV infected groups, and they settled on oxygen saturation less than 90%, chest indrawing, wheezing, refusing feeds, and malnutrition as the categories that they wanted to score, and you can see how they weighted these scores. And then they did a similar process with HIV-infected kids and added on CDC HIV classification as well as age group here. And so what we did, and they found that the performance of the score was very good. So the C statistic, which measured the probability that the mortality was being predicted more than chance, was 0.92 in the HIV uninfected and 0.7 in the HIV infected, which are acceptable C statistic thresholds. And so what we did is we took the hospitalized patients in our data set, and we sought to externally validate the risk score in the Malawi data set. This hadn't been done yet. And one of the challenges that we faced in Malawi is that HIV testing is still, systems are still weak and inconsistent, particularly at the hospital level. So although that we fully recognize that HIV status is an important driver of child mortality, the reality is that it's not always available as a risk to assess. And so we did not use that actually ultimately in our data set. But what I wanted to point out here is that the risk score, so we used the risk HIV uninfected score, and we applied that to the different HIV status strata and found that it basically performed similar. All the confidence intervals overlapped. And so we came up with, basically our final result was that the risk HIV uninfected score performed with a C statistic of 0.72 in our data set, which is an acceptable level. What we decided to do as a next step is to adapt the risk score a little bit further to be more practical within the Malawi health system. And so this is just an example of adapting a risk score to the local epidemiology and health system capacity. And so we basically kept the same categories, but we added in a moderate hypoxemia threshold to kind of better take into account the gradation of risks associated with oxygen hypoxemia. We, instead of using weight for age, we used mid-upper arm circumference as a more practical measurement of malnutrition, and again added in a moderate malnutrition metric to take into account that gradation. And then we included female wheeze and unconscious in our model. And then
2 minutes.
Yeah, and then basically what we did as a next step is then we ran this adapted score within our data set. And the point here is really that we came up with these different thresholds that we could use to basically decide whether a patient is high risk or not. And you can see the proportion of patients who would be identified as high risk for mortality within these different score thresholds. And the point here is really whatever score you choose as a threshold is likely associated with the capacity of the system you're in and what intervention you link that to. And so it may be that data support tools such as tablets will be needed here. And then again, this bubble CPAP as a potential intervention which severity of illness scores might feed into. This is an intervention that has a lot of potential, but it's unlikely to be widely implemented given resources. So in sum, how effectively we stratify child pneumonia mortality risk is likely to be important in reducing mortality moving forward. Simple tools are needed in the outpatient sector, such as pulse oximetry. more nuanced tools that can account for the interaction of risk factors are likely required at the hospital level, and tailoring that risk stratification to local disease epidemiology and health system capacity is important. Thank you.
Thank you very much, Eric, for an excellent, clear presentation. If I could start with a question, and we'll have time for some other questions or comments. You found that there was quite a lot of children without indrawing who are hypoxemic, correct? Yeah, so around 30% or so.
These were patients actually within, so they actually had indrawing, yeah. But that last bullet was trying to emphasize that the current WHO classification doesn't refer those patients.
Right. Yeah. Okay. I was just wondering whether in terms of grading risk, you probably remember the work of Trevor Duke and others in Papua New Guinea, where really the mortality doesn't really start to rise until you get down well below 80%, in fact, and that, you know, whether you were able to look at bringing in other levels of hypoxemia in terms of grades of risk. And yeah.
I mean, I think some of that may have, you know, the Papua New Guinea setting is a higher altitude setting, and so that I think is likely to influence that data. I think it would be difficult, at least in the Malawi setting, to we could look at that, I suppose, in terms of these lower risk kids. There's probably going to be a strong association with HIV in that as well. We'd have to account for. Yeah.
Andrew.
Thanks, Eric. It was great. I just was interested in terms of risk stratification. Certainly in the Botswana setting, we're seeing more and more children surviving with cerebral palsy, and they seem to do worse, at least in terms of length of stay. We don't know yet, but they do worse in terms of mortality. I just wondered whether you had any comment on neurologic diseases as a risk factor for adverse outcome from what you've seen or looked at so far.
I think it certainly is. In the Malawi setting, I think it's not coming out in our data. You know, most likely those are patients who are going to be classified as having meningitis in a routine setting, possibly, which we do know is a predictor. But at least in this data set, it's not enriched enough to look at a cerebral palsy type patient.
Yeah.
Maybe a similar angle related to wheezing and inhalation with short acting. So what about asthma? As a potential risk factor to rule out, confirm?
Yeah, so what our data showed was that wheezing was protective.
Could you repeat the question?
So
It's really getting after wheeze. And is wheeze protective as a risk factor? And the answer, at least in our data set, is yes. In the PERCH data set, it also looked to be protective. And so I think, broadly speaking, I think yes. So I think wheezing tends to be a protective variable, risk factor. Yeah.
Many thanks. Thank you very much.
Okay, so this is Steve Aston from the University of Liverpool. I'm the infectious disease doctor in this region, but with data from Malawi. Thanks, Steve.
Thanks, Jamie. Good morning, everyone. I'm grateful to the organisers for inviting me to come and talk to you a little bit about this topic. So this is picking up where Eric left off. As the children get older and survive their first episode of pneumonia, what happens when they get their second, when they're an adult? I have no conflicts of interest to declare. So picking up in a similar vein, I'm going to talk about this aspect of severity assessment in pneumonia. Unfortunately, in the adult literature, the work on this in a developing world setting is much more limited. So I'm going to draw on lots of the work that has been done, the extensive work that has been done in a well-resourced setting, and thinking about the parallels that we can make to a developed world setting. Thinking about talking a little bit about the methodology behind deriving these clinical prediction tools, and thinking about actually how practically they can impact. I've got some data from Malawi that I'll share with you about my own work there, and draw parallels with that between other African pneumonia cohorts, and then think again how we can integrate these into pneumonia management. So as we all know, community-acquired pneumonia in adults is incredibly common, but it's also incredibly variable. We know that it can vary from a mild, almost self-limiting illness to a acute fulminant disease process complicated by respiratory failure and sepsis. And that's borne out in the mortality rates that you see in different pneumonia cohorts in different settings, ranging from less than 1% to greater than 50%. And what's crucial is that your initial treatment management decisions really do hang upon that assessment of risk, the risk of adverse outcome. You know, are you going to choose that this patient needs to be hospitalized? It's going to have a bearing upon your antibiotic choice. And if you get this wrong in either direction, there are potentially adverse consequences. So overestimating the disease severity obviously might lead to unnecessary hospitalization, unnecessary exposure to broad spectrum antibiotics. And I guess the underestimating the disease severity, the risks are obvious. And the difficulty is that left unaided, so the gut instinct of clinicians, we frequently get this wrong. So there's a classic kind of questionnaire-based data that preceded one of the big there's kind of the prelude to one of the big pneumonia severity assessment tools that surveyed clinicians and gave them examples of very low-risk patients, and they consistently overestimated the severity of disease. There are data in another direction. That data here is from New Zealand, where amongst the group of patients that died, the initial clinician, sorry, where's the laser pointer? Not to worry. In the right-hand column there, amongst the patients who died, only approximately 2/3 of them were thought to have severe disease at presentation. So how do we address this? Well, we can look for risk factors, and this has been done repeatedly, look for risk factors for adverse outcome in pneumonia. And we've all seen lots of tables like this, and all these risk factors are very, very familiar to us. But when dealing with the individual patients, knowledge of this list is not very useful in directing care. So how can we incorporate these into something that's a bit more workable? And what we move on to is, and there's been a plethora of these designed in adult pneumonia, is a series of clinical prediction tools. So incorporating these various risk factors, weighting them appropriately, and to help them to give an estimate of the probability of a particular outcome, a particular adverse outcome. And then on the basis of the risk to kind of stratify people into various groups. I did just want to this is slightly dry, but talk about the methodology behind these clinical prediction tools, because it has a bearing upon how we interpret them. So as computer technology and statistical packages have become, available to all of us, we can run quite complex multivariable regressions and easily kind of develop or derive these clinical prediction tools. I guess the difficulty is when we kind of think about the data sets that we're using to that, you have to be confident about the data set that you're using. Is it just registry data? Is it a prospective study that you've specifically designed to kind of look at this? You have to think about your outcomes. Are the outcomes that you're trying to predict the appropriate outcomes? Are they clearly defined? What about the predictors you're using? Are they the right predictors? Did you define them a priori? Are they actually predictors that will be available in the setting that you want the risk tool to be used? The next aspect is once you've derived it, you have to appropriately assess the performance of a particular tool. And this is done in a number of ways. We think about the calibration of a tool. Does the predicted risk correlate with our observed outcomes? Another way of doing it that Eric has alluded to in some of the children data is looking at the discrimination of a tool. Does it distinguish effectively between those who are likely to have an adverse outcome and those who are not? And frequently use this, the area under receiver operating curve, or so-called the C statistic, as a summary measure of the predictive, of the discriminative quality of a diagnostic tool. More intuitively, if you have a tool that produces a range of outcomes, you can choose your thresholds. You can say to identify either those at low risk or high risk, and then you can apply a sensitivity or specificity testing to help you in your clinical decisions. The most important thing, and I think this is frequently forgotten, is the need to validate any tool that you develop. Sometimes this is just done within the data set, so-called internal validation, where you do some resampling techniques. But really that is inadequate in and of itself, and there's absolutely no substitution for some form of external validation, where a tool derived in a particular population is trialed in other populations. And as the validation populations are increasingly dissimilar to your derivation population, you get increasing confidence that this is actually a tool that can be used. But it doesn't stop there. We need to assess the impact of these tools. So all of these tools are kind of predicated on the assumption that improving prognostication allows clinicians to make better decisions. But actually, does that bear out to having improved patient outcomes in practice? And so that is an assessment that's not just a measure of the tool itself, but a measure of the pathway for which it links onto. So on the basis of your risk stratification, what different decision tactics do you suggest that clinicians do? And it also has a bearing and reflects upon the usability of the tool. Can clinicians actually remember the tool that you use? Is it easy to use? Do clinicians trust the tool, or will they override the particular decision of that? Unfortunately, assessing the impact of these, measuring the impact of these, it becomes increasingly complicated, and oftentimes it relies on fairly elaborate clinical studies to do this. So that's a bit of background thinking about how we derive and how we conceptualize these tools. And I just want to bring a couple of examples. So people who work in well-resourced settings, particularly in the Americas, will recognize this, the Pneumonia Severity Index. And this is the archetypal pneumonia risk assessment tool that was derived in a huge population in the States, greater than 50,000 individuals, derived on registry data. And it was asking the question, how do we identify those people at low risk that we can send home? And what it came out with was, on the top left-hand side there, a relatively kind of complicated algorithm that relied not only on a fairly detailed history and examination, but also a series of laboratory factors. This tool has been extensively validated in lots of different settings and has thought to have fairly good predictive value, an area under the receiver operating curve, or a C statistic, of 0.81, which is very good or excellent discriminatory capability. The criticism of the Pneumonia Severity Index is that it's elaborate, it's complicated, and usually you need computer support to be able to kind of calculate that the PSI quickly. So a British group put together this, the CURB-65, and this is a 5-point severity assessment tool based on the presence of confusion, raised urea, raised respiratory rate, low blood pressure, or advanced aged. And on the basis of these 5 parameters, we're able to kind of stratify people fairly effectively into mild, moderate, and severe categories of disease based on their 30-day mortality risk. And again, this has been extensively validated in lots of settings, and also and its simplicity lends itself well to incorporate into pneumonia guidelines. And this is present in British guidelines and also in American guidelines. And its discriminatory capability is comparable to the PSI. As I've mentioned and kind of alluded to, it's very, very easy to derive these tools. It takes a bit more effort to validate them, but what about measuring the impact? Do they actually have a bearing upon patient outcomes? And for these tools that I've just mentioned, there is some evidence of impact on patient outcomes. So this is a study looking at the impact of the Pneumonia Severity Index, and a group of kind of health implementation experts tried to encourage clinicians to use this in practice, and they had a variety of interventions, what they called low intensity, moderate intensity, and high intensity, in terms of how encouraging they were for the clinicians to use it. And what they found in the settings where they put in lots of effort to encourage the use of Pneumonia Severity Index, that there was a significant increase in the proportion of patients, of low-risk patients, that could be managed in an outpatient setting. And that was done without any delirious or deleterious consequence in terms of patient safety. We've got similar data for the CURB-65 tool, again in a developed world setting, saying if you encourage patients if you link the severity in terms of explicit antibiotic prescribing policy, then you can use there's data to indicate that CURB-65 can effectively reduce the use of broad-spectrum antimicrobial agents, and again without any detrimental effects on clinical outcomes in terms of mortality or clinical failure. I think there's a point here that probably pertains particularly to adult pneumonia, maybe less so than it does to child pneumonia, is that are we predicting the right outcome? So both of the tools that I've mentioned before predict 30-day mortality. But in terms of, you can conceptualize severe pneumonia in several other ways. You know, if I had an episode of pneumonia that led me to the ICU department, but I escaped from it, I'd still call that severe pneumonia, even though I survived. And the reason why this point is salient is that if you look at adult pneumonia, particularly in developed world settings, only 50% of the mortality that occurs in the following 3 months is actually explicitly related to that pneumonic episode. And so, by corollary, half the deaths are non-pneumonia related. And so is necessarily predicting that outcome the best strategy to kind of rationalizing your treatment. And similarly, in developed world settings in particular, there's often some degree of treatment limitation in older adults, and that can be explicit in terms of, you know, not escalating to the intensive care department or implied. And by predicting 30-day mortality, you're necessarily weighting your tools to those things such as advanced age or comorbidity, which means that you might underestimate disease severity in younger patients. And in terms of thinking how can I use these tools to direct my acute interventions in terms of my supportive care, in terms of my antibiotic strategies, is predicting the 30-day mortality necessarily the best tool? And you can see the table at the bottom that the pneumonia severity index, that if you look at alternative outcomes, its discriminative capability becomes less than with 30-day mortality. So in response to these, we've got other tools that have been developed which predict the requirement for ICU care. So the requirement for a person to be mechanically ventilated or to need vasopressors. And these are much more based on physiology rather than on comorbid risk. These have been less widely validated and less frequently used. But enticingly, there is some data to suggest that they can have a really significant and meaningful impact on patient outcomes. These are data from Singapore, which in a before and after clinical study design suggested that they would use this risk assessment tool on the right, the so-called ATS severity assessment criteria, and they use the presence of these minor criteria to identify patients with severe disease. And if, according to that tool, they are stratified as severe pneumonia, they implemented a bundle of rapid resuscitation strategies. And in a before and after design, they identified remarkable effects in terms of mortality, hugely significant reduction in hospital mortality, also a significant reduction in the number of people that are admitted to ICU, and really importantly, a number of the people, and in particular, the number of people that had a delayed admission to ICU. So they didn't sit on the ward for a couple of days deteriorating before they were admitted to the intensive care unit. Okay, really. So I'm just going to flick over some of this in particular. So I want to move on to some of my baseline, my data from Malawi. So I looked at a study in Malawi, which has tended to replicate some of this work in a low resource setting in Africa. So I did a prospective study of clinically diagnosed pneumonia attempted to identify the risk factors predicted of 30-day mortality. And just in terms of the baseline characteristics, what's unsurprising is that the population had the population spectrum was the young adults and had an absence of kind of chronic cardiovascular and pulmonary comorbid disease, which is present in which is more often seen in kind of well-resourced settings. In well-resourced settings, community-acquired pneumonia is often a disease of the elderly and the comorbid. So in this pneumonia cohort in Malawi, we sought to identify the factors predictive of adverse outcome, and we found that male sex, prolonged symptom duration, tachycardia, hypoxia, and inability to stand were all predictive of adverse outcome. In this pneumonia cohort in Malawi, we sought to investigate the effectiveness of currently available severity assessment tools. And the CURB-65 tool was very poorly discriminative. It had very poor sensitivity for identifying those adults who were at high risk of dying, with a sensitivity at the standard threshold of greater than 3 of just 14%. We attempted to improve this by developing an alternative severity assessment tool called the MOST score, based on male sex, oxygen saturations, inability to stand, and tachycardia. And in this, obviously in a derivation cohort, this was much more discriminative and much more useful to identify those patients at high risk of death. So If we look at other African cohorts, there have been a couple of other cohorts that have similarly kind of highlighted the fact that severity assessment tools developed in well-resourced settings are actually poorly predictive in this population. And that may relate to disease etiology, may relate to differences in demographics or comorbidity burden. In terms of HIV, clearly HIV is a factor that's very present, and in how this should have a bearing upon our acute assessment of those. In a meta-analysis of studies from sub-Saharan Africa, I didn't find any evidence that HIV acutely impacted community-acquired pneumonia outcome. So just finally, what I want to do is to think about, well, by way of illustration, how can we use these tools in low-resource settings? So I want to say that this is the tool that I've developed in Malawi, but I want to highlight the fact that it's not externally validated, and we can't really play as great a store in it. But by way of illustration, I think it's useful. So we could say that we want to use our tool to identify those people at low risk of death who can be effectively safely discharged. And the reason why that might be useful is that you decrease the burden on the hospitalized the hospital burden. I guess thinking about that pathway in terms of the practical outworkings of that, there are some mandatory investigations that you need to do in these patients. You need to exclude TB, you need to HIV testing them. So within your health structure, can you incorporate those mandatory investigations in that group? If instead you want to say, I want to identify those patients with severe disease, what you need is actually a score with better positive predictive value for death. And so you may need to include additional criteria. So, for example, anemia, multilobal consolidation. And I think as Jamie alluded to in his introduction, when you go down this pathway of separating the so-called moderate severe from the highly severe disease, what follows and the effectiveness of this pathway really hangs on the interventions that you're able to implement. And I think we've already alluded to the fact that there's huge numbers of questions in this, the most effective management. What is the most appropriate antibiotic strategy? Do we introduce empirical TB treatment or empirical PCP treatment for those with high severity disease? How do we correct hypoxemia and fluid resuscitate? Just very briefly in passing, obviously we need to validate things in a low resource setting. It's a worthwhile question to say, are we on a hiding to nothing looking at disease-specific severity assessment tools, or do we need a more generic severity assessment tool? And I'll leave Eniton to answer whether biomarkers can answer that. So just very briefly in conclusion, prognostication pneumonia is challenging. Clinical prediction tools can potentially improve things, but we need to derive tools that are applicable to low resource settings. These obviously need to be validated before they can be used. Okay, sorry for running over.
We have time for some questions. If you have a question, would you please go to the side and use some of the microphones. But to start us off, these severity scores seem to be the curse of the stats package, really.
Yeah.
In terms of we can all get an answer to identifying patients, but you can't change their age, you can't change their sex. And as you alluded to, you need to adopt some treatment on the back of what you're finding from your severity score. Is there a way of thinking about this backwards, thinking about what treatments you have and identifying patients who are most going to benefit from it?
I think that's absolutely right. When you develop severity assessment tools, you can put in a load of factors and you can get almost any answer you want. And so in that kind of derivation process and validating it, I think that you've always got to have that focus. What am I trying to predict? And I think really what you're trying to predict is modifiable mortality. Which group of patients with my acute interventions can I help? And I think particularly identifying those factors that predict modifiable mortality.
Any other questions for Stephen? Okay then, thank you very much. So I'll ask Eniton Carroll to give a presentation on biomarkers. Thanks, Eniton.
Thank you very much, and thank you to the chairs for asking me to speak. Thanks also to the previous speakers for setting the scene and for introducing my topic. So what I'm going to say hopefully follows on very nicely from the two previous speakers. I have no conflicts to declare, but specifically I should say that I have been a member of the NICE Sepsis Guideline Development Group. I do some consultancy work with a couple of diagnostics companies with whom I collaborate, but I have never received any personal funding from any of these commercial partners, and any funding goes directly to my employers, the University of Liverpool. So very briefly, what I'd like to introduce is talk a bit about omics technologies and their role in biomarker discovery. I'd also like to just show some data from some metabolomic studies, proteomics, and then finally end with future perspectives. So to begin with, what are omics technologies, and are these really relevant for resource-poor settings? And yes, I do believe they are. So basically what this refers to is, as you can see on this slide, the genome, the transcriptome, the proteome, and the metabolome. And these actually define an individual's, both their phenotype, which you see clinically in front of you, and their function, how they present, how ill or how well they are. And by understanding these omics facets, I believe that they provide improved mechanistic understanding of the diseases that we study, in this case pneumonia or bacterial sepsis. And by understanding the underlying mechanism, we're better able to derive biomarkers that pertain to particular diseases for improving diagnosis. And also, not just diagnosis, but also prognosis. So this slide is taken from this review article, and sorry, it's a bit blurred, but what it's trying to say is that an individual's age, as we've heard from the two previous speakers, their underlying comorbidities, their environment, things like pollution, malnutrition, genetic factors, all combine together to define what their metabolome is. And then that also defines the phenotype, the patient we see in front of us. And that phenotype helps us understand which therapies are appropriate for particular patients, how they're likely to respond to particular therapies, and their risk stratification. So everything the previous speakers have mentioned actually can perhaps be derived from understanding the metabolome. And in particular, with reference to pneumonia, we're thinking about appropriate therapies, as Jamie alluded to earlier on, antibiotics, fluids, or oxygen. So I'll start with this breath analysis because we're talking about pneumonia. And I understand that an individual breathes about 20,000 times a day. I'll ask the respiratory physicians if that's correct, but so I'm told. And if that is correct, then for the diagnosis of pneumonia, then breath is an obvious sample, because if you've got disease in your lungs, what comes out of your lungs surely should be a very good diagnostic test of whether you have bacterial or viral pneumonia or TB. So this, just going through this slide, we look at collecting the sample, and then if these samples are then put in through whether it's mass spec or gas chromatography, what is collected are called volatile organic compounds, or VOCs, and then the most discriminating metabolites are selected, and these are put onto a platform to derive a diagnostic test. There. So this is all very theoretical, I guess, but I'd like to just talk about a study. This was done on an intensive care this is from Manchester, Roy Goodacre's group, and they took patients who were not infected on admission. So these are patients who had sterile brain injury, and they had this collection system where the ventilated patients had their breath collected in this bag, a special bag, and they were analyzed by chromatography and mass spec. It wasn't a massive study, it was under 50 patients, but most of them had negative blood and respiratory samples at baseline. And most of them also stayed negative for the duration of the study. However, in those that had infection, they identified mainly Haemophilus and Staphylococcus aureus. And these are principal component analysis graphs, where the principal component is the direction PC1 and PC2, is the direction along which the samples show the greatest variation. And what we have here are the different time points during their stay on intensive care. And we can see here that the infected patients are those with the solid circles here, and the ones with the open triangles are the non-infected patients. And we can see here that there are clearly differentiated profiles between infected and non-infected at different time points on intensive care. So this suggests that the breath analysis could help to discriminate infected from non-infected cases, potentially viral from bacterial. Now, I put this up because this was the cover of the issue in which this study was reported. And what this shows here is the discriminating volatile organic compounds between infected and non-infected, which have been put into the shape of a lung, which I thought was appropriate for this conference. And the areas of high density and low density are the chemical structures that were identified. So next, I want to just talk about this study. This is in children who had empyema, or parapneumonic effusions with Streptococcus pneumoniae. And in this study here, you can see again, it's the same concept, a principal component analysis, showing separation between the groups. And the red group is those who had complications from their empyema, and the green ones had no complications. We can see here that there is some separation, but clearly there's this degree of overlap here, so not really perfect test. And these here just refer to the spectra, that differentiating spectra on NMR spectroscopy. So this here is a heat map, which looks at on the columns represent the patients. The red patients are complicated, and the green patients are non-complicated. And the rows represent the metabolites. Red is up, increased expression, and blue is reduced expression. And we can see here some of the metabolites that are involved in complicated pneumococcal empyema, and helps to understand a bit more, as I said, about the pathophysiology of pneumococcal empyema. So in this study, looking at, again, metabolomics in adults with community-acquired pneumonia, this was using blood samples. This Z-score just demonstrates the magnitude of the metabolite difference. So on the left here, we have controls, and on the right, we have cases, and we have here, which you may not be able to see, is the metabolites, amino acids, peptides, carbohydrates, nucleotides, and cofactors and vitamins. And we can see lipids, in particular, amino acids, are much more differentially expressed, present in those who had increased mortality compared to those who survived. And all of these had community-acquired pneumonia. So perhaps, potentially could be used to define prognosis. So in this study, this was also a study where metabolomics was used to differentiate sepsis from systemic inflammatory response syndrome, or SIRS, and those with sepsis had severe sepsis, and septic shock. So not all sepsis is the same. It's a heterogeneous condition, and we can see here an overall profile showing the differentially expressed metabolites. And on the right here, we have a receiver operator curve, which has already been explained, where the compared combination of these metabolites, which are the sphingolipids and the glycerophospholipids, combined here with traditional biomarkers, CRP, procalcitonin, and interleukin-6. And we can see here that the combination of the two metabolites provided better discrimination. And the area in the curve of 0.9 is actually quite good. So in the same study, again, apologies for the heat maps, but again they show here, the rows are the samples and the columns are the metabolites. On here you have a bar which shows the patients with inflammation in white and the patients with sepsis there on black. And you can see, just looking at the heat map, there is some discrimination between those two groups. Now, the stratified because not all sepsis is the same, for community-acquired pneumonia, intra-abdominal infection, and bloodstream infection. And I think you can see quite clearly that these three groups stratify quite nicely, but particularly for pneumonia, which is the focus of this talk, biogenic amines and glycerophospholipids appear to be much higher than in the other groups. So again, perhaps suggesting that you could discriminate between pneumonia and other forms of sepsis. When you look closely at this particular metabolite, glycerophospholipid, again, same heat map, community-acquired pneumonia, intra-abdominal infection, urinary tract infection, bloodstream infection, these really all seem to cluster very closely together here. But here we can see pneumonia standing out really quite strongly, this one in white here, with a very distinct metabolite pattern. So this perhaps could be used to determine etiologies of sepsis or etiologies of pneumonia. And finally, from this paper, a very good example of risk stratification, this particular metabolite, putrescine, which is involved when there's breakdown of amino acids. If you had a level greater than 0.072, you were more likely to die. So really, really clear discrimination based on your level of a particular metabolite in terms of prognostication. Now, this is some data from Liverpool, our intensive care. This is children who are admitted to intensive care, so all critically ill children. And we had three groups. We had those who were admitted for elective surgery, who had no infection at admission, did not develop infection, so the non-infected group. And then we had those who had bacterial infection and those who had viral infection. And we can see here that whilst there's very good discrimination from those who are not infected from those who are infected, there's a bit of blurring here in the middle between bacterial and viral, but you can see some degree of separation here based on, this is NMR metabolomics. And so again, suggesting that perhaps these are blood samples, plasma samples, that perhaps this could be used to help discriminate etiology in pneumonia and to decide whether to give antibiotics or not. It could also perhaps be used to help to define whether patients need oxygen or fluids based on what metabolites are expressed. So this is a study from China looking at proteomics profiling in patients who had active TB, lung cancer, and pneumonia. And it wasn't a huge study, but they had a good number of patients in each group, and they could see clear differences, particularly in these three proteins, S100, this SOD3, which is a superoxide dismutase, and a metalloproteinase 9. So very clear examples that perhaps these three proteins, when they were combined into an ROC curve, they were able to discriminate between healthy controls on the left panel and pneumonia on the right panel. So I know that this conference focuses on resource-poor settings, and there, as previous speakers have said, not many studies using omics technologies. This is one from the Gambia, validated in Kenya, using MS-based proteomics. And they identified a number of discriminating proteins, but in particular, this one called lipocalin, which was identified as the best protein biomarker for severe pneumonia and bacteremia. When this was combined with haptoglobin, it was able to differentiate between pneumonia, bacterial pneumonia, and respiratory distress due to malaria. This is very interesting because in work we did in Malawi, which I can't show you in the interest of time, we also identified lipocalin as a discriminator of serious bacterial infection, not just pneumonia. So when lipocalin was compared to other biomarkers such as C-reactive protein and von Willebrand factor, it had the best discriminator, 0.9, which is very good discrimination with good positive and negative likelihood ratios. So back to some more proteomic studies. And on the left here, this is a study using proteomic profiling of plasma in patients on intensive care with ventilator-associated pneumonia. And on the left, we have another this is a three-dimensional principal component figure. Normal controls, again, separate very clearly, and those with acute lung injury separate as a separate group. But within that, it's difficult to say there's any separation between those that had ventilator-associated pneumonia in pink, and those that didn't have in orange. When you looked at the heat map, you have them here, the ones who had the ventilator-associated pneumonia in pink, the few of them who misclassified. It does suggest that there is some discrimination here in proteins between those who do have VAP and those who don't. So then they reduced the total number of proteins, which were about 28, to 3 proteins that they thought had the highest discriminating value, actinin, S100A8, which we've seen before, and lactotransferrin. And when you combine them, those gave very good discrimination between the VAP group and those that didn't have VAP. So, to conclude, what does all this mean, and how is it relevant for studies in research poor settings in identifying etiology of pneumonia or in trying to risk stratify patients with pneumonia? Well, I believe that for us to be able to effect any positive effects or to demonstrate any impact, we need to have a very well-designed study. So initially in the biomarker stage, these studies need to be designed with a clinical question in mind. And what I've learned from my work, collecting samples either in Malawi or in the UK and then going to talk to a metabolomics or proteomics expert, is that's very much the wrong way around. That we talk to them before we start the study, before we start to collect the patients. Very simple things like the type of tube that you use, whether it's lithium heparin or whether it's citrate or whether it's EDTA, absolutely hugely affect the type of omics that you can do. So these studies should really begin with what is the clinical need, which I think has been very well expressed in this session, in that we need to be able to stratify patients to decide whether to give them oxygen, fluids, or antibiotics. So we need to discuss that with our omics experts before we start the study, and so that they can advise us on when to take the samples, how to take the samples, and particularly how to design our study, not the other way around as it tends to happen with clinicians. So we define a clinical need, and then we select our patients and controls and design very well studies, robust studies, which are then validated as Stephen has alluded to in different populations. So my final slide is an answer to the question I was asked: are new diagnostics on their way, or are they far away? I believe they are on their way with the advance in omics technologies. And perhaps you might say that these technologies are very far away from resource poor settings. And I would disagree with that, because the rollout of point-of-care diagnostics for malaria and HIV, particularly in sub-Saharan Africa and in Asia, has demonstrated that point-of-care technologies do have a huge potential to transform completely the management and the landscape of these diseases. So whether that point-of-care diagnostics is blowing into a bag, or blood, a finger prick sample, or a urine sample, these can easily be applied to point-of-care tests, which gives either qualitative result or quantitative reading at a healthcare center, not necessarily in a hospital, and preferably technologies that don't require electricity or refrigeration. These can be transported to a mobile device, which is widely available in these settings, telehealth to a central hospital, and there in the health center, the clinician is able to give a diagnosis and decide about referral or treatment. And so I'd like to end with that, and thank you for listening.
Many thanks, Anatan, for exciting presentation and a great update on, I agree with you, the need for better point of cares for such an important clinical challenge. Are there any questions? Yep, Steve, can you go to the microphone if it's okay?
Thanks, Anatan. So lots of time when sick children or sick adults come into hospital, their initial management is almost a reflex. You kind of start things then. I wonder, particularly in adults, there's a sense that you add in incremental therapies if people are failing to improve. And so I wonder whether the role for biomarkers is not just at the front door, but subsequently in identifying people that are failing to improve. And I wondered if you could highlight any that you think fulfill that role.
So I think that's a very good question. So I think if you don't mind me going back to sepsis, which is what I spend most of my time doing, that's a very good analogy. Sepsis in children as well is a very much a more and more approach. So you try something, it's not working, add some more inotropes, add something else. And so I think that what that leads to is a delay in getting to the right treatment, because you've tried this and this and this. Whereas I think if you stratify at the beginning, then if it's a robust stratification, you can then identify straight away which patient is going to benefit from treatment A, B, or C, and you administer treatment A right there at the beginning, and you avoid that delay. So I do think it's at the front door. I do think it helps determine who needs referral to a health center or to a hospital, central facilities, or who actually is going to die. And therefore, these are the ones that need your very limited supply of oxygen, for example.
I think, Anatan, we've been looking at two critical questions. One is trying to identify those that might die, so very compelling argument, reducing mortality. The other one is the choice of antibiotics, and increasingly compelling given the focus we have now on antimicrobial resistance challenge globally. Is that focus going to, you think, change the opportunity for funding that's going to lead to more and more better point of care work? Is that starting to happen, or how do you see the future in that?
As you know, that certainly in the UK and I think in well-resourced countries, there's now this clash between surviving sepsis, because that's stop people dying, give antibiotics early, and antimicrobial resistance, don't give too many antibiotics. So there's that conflict. Yeah. But I think for antimicrobial resistance, it's firstly, withholding antibiotics, that's in initiation, but also in the stopping. And I think point-of-care diagnostics have a role in both of them. And I think the only way to robustly define is by large randomized controlled trials.
Great. Okay, so I think if there aren't any questions, thank you very much, Anatan.
Thanks, Anatan.